1 out of 4 people who is looking at this elephant has diabetes or carries the risk for diabetes. This reflects the current situation in my country, in Turkey. This is one of the award-winning posters of a contest for diabetes awareness in Turkey. I don't know if this applies also in this room, but in Europe, this number would be 1 out of 7 people. In 1990s and 2000s, large-scale randomized controlled trials have clearly shown that in populations at risk for diabetes, relative risk reductions up to 58% have been achieved after 3 years with lifestyle modifications only. But in real life, the numbers indicate to a growing epidemic. Back in the year 2000, in the first edition of Diabetes Atlas by by International Diabetes Federation, it was estimated that globally there are 151 million people with diabetes, and that all signs point to this alarming figure rising even further in the coming decades. In 2017 estimates of International Diabetes Federation, currently 425 million adults aged 20 to 79 years worldwide are estimated to have diabetes. The number increases to 451 million if the age is expanded to 18 to 99 years. No country is immune from diabetes. An even bigger problem is that about 79% of people with diabetes live in low and middle-income countries. After so many years of these landmark studies about diabetes prevention, the numbers are still rising. The predictions for 2045 are even worse. If this trend continues, 629 million of people aged 20 to 79 years will have diabetes at that time. If the age is expanded to 18 to 99 years, this number will increase to 693 million. These are huge numbers, and the largest increases will take place in regions where economies are moving from low income to middle income levels. More than 1/3 of diabetes cases are estimated to More than 1/3 of the diabetes cases are estimated to result from population growth and aging. 326 million of people with diabetes are aged 20 to 64 years. We can say they are at working age, and about 100 to 23 million people with diabetes are aged 65 to 99 years. 2045 predictions are that the number of people with diabetes aged 65 to 99 years will nearly double, so the increase is much more striking than in the working age population. Likewise, the economic burden of diabetes will increase in the next decades, particularly among elder age groups. We know the risk groups and how to screen for diabetes, but no country has diagnosed every person with diabetes. IDF estimates that 1 in 2 adults with diabetes are undiagnosed, which makes the case for complications more difficult. Diabetes accounts for nearly 11% of global all-cause mortality among people in this age group. This is higher than the combined number of deaths from infectious diseases, HIV and AIDS, tuberculosis and malaria. In this age group, about 46% of deaths to diabetes are in people under the age of 60 years. Diabetes imposes a large economic burden on individuals, their families, national health economic systems, and countries. Healthcare expenditure for people with diabetes have been found to be 2 to 3-fold higher than people without diabetes. The healthcare expenditure on diabetes for the people aged 20 to 79 years has grown from 230 billion US dollars in 2007 to $727 million. When using the expanded age group of 18 to 90 years, the cost is estimated as $850 billion. The age group with the largest expenditure, about $127 billion, was 60 to 99 years. This group is followed by people aged 70 to 79 years, and then those aged 50 to 59 years. As the projections for 2045, two findings are striking. On one hand, expenditure for people less than 50 years of age will remain more or less stable in the next decades. On the other hand, the expenditure of people above 70 years will grow by 37% due to the aging of the population in countries with highest expenditure on diabetes. This again shows how important it is to have programs and policies for healthy aging with a life course-oriented approach in these and other countries. People with diabetes have an increased risk of developing a number of serious life-threatening complications in the long term that affects their quality of life and also in more advanced stages, seriously threatening the life. Their common denominator is that their burden can be prevented. Today, we cannot definitely prevent the complications, but we can delay the onset and prevent or slow down their progression by good control of systemic factors and early detection and timely treatment of these complications. But in real life, the prevalence of end-stage renal disease is up to 10 times higher in people with diabetes. Every 30 seconds, a lower limb or part of a lower limb is lost to amputation somewhere in the world as a consequence of diabetes. Diabetic retinopathy is still one of the most feared complications of diabetes. Klein and colleagues have looked into the relationship of period of diagnosis to the prevalence of visual impairment in people with type 1 diabetes. For most duration of diabetes groups, the prevalence of visual impairment was lower in those diagnosed more recently than those diagnosed earlier. But still, diabetic retinopathy remains a leading cause of preventable blindness in the working age population. A meta-analysis of 35 studies around the world published in 2012, they estimate that there are approximately 93 million people with diabetic retinopathy. 17 million of them have proliferative retinopathy and 21 million have diabetic macular edema. 28 million people have the vision-threatening disease. Each of these numbers represent a bigger population than many countries around the world, as well as in the European region. Another study from US estimated the numbers for diabetic retinopathy and some other diseases among the people aged 40 years or older for the years 2005 and 2050. The projections show that the number of people with retinopathy and vision-threatening disease will almost triple in 2050. A larger growth is expected among those 65 years or older. Not only blindness, but moderate to severe visual impairment due to any cause has significant impact on the quality of life of the affected person and is associated with deterioration of physical well-being, may cause limitations in performing daily activities, and may affect their social integration. All these also affect their families, their friends, and their social environment. Besides the burden for people with diabetes, diabetic retinopathy is also responsible for significant health expenditures. So it's very sad that at a time when we have the evidence and medicines and technologies to better care for people with diabetes, for early detection of retinopathy and timely and effective treatment of the vision-threatening disease, we are still not successful in translating the evidence base into the real life of people with diabetes and reduce the burden of the disease. As IDF Europe, we have focused on the barriers in integrating diabetes evidence into practice in our recent publication in 2017. I strongly believe that more or less most of these barriers apply for the case of diabetic retinopathy. I want to share some of the results of our member survey. As the International Diabetes Federation European region, we have 70 member associations across 46 countries in Europe, and some of our member associations are scientific organizations. Some of them patients organizations only, and most of them are mixed organizations. In this publication, we use data from different sources, including a survey to have the perspectives of our member associations. Our member associations from 38 countries out of 47 responded to our survey. The questions differed for healthcare professionals and people with diabetes according to the constituencies of our member associations, but have been presented together where possible. The findings of this report have identified a number of key barriers to implementing diabetes evidence into practice at the level of the healthcare system, healthcare professionals, and patients. One of the most striking findings of our survey is that despite the number and its burden, the respondents perceive diabetes to be of medium priority at the national level. Many countries lack a comprehensive multi-sectoral approach to diabetes, meaning a national diabetes program or a national diabetes strategy. If they have a plan in place, the target population for these programs varies, and they don't use effective mechanisms for the implementation, monitoring, and evaluation of national diabetes plans. If there is a national diabetes strategy, diabetes registry, in many countries, there is a problem with their use and structure in many of these countries. There is a lack of effective involvement from healthcare professionals and people with diabetes in the development of new public policies. The resources, be this human resources, facilities, or funds, are not distributed evenly in the country. The identified top 4 barriers by healthcare professionals are poorly supported or implemented primary, secondary, or tertiary prevention programs, limited time for consultations, ineffective communication between the healthcare professionals, and lack of integrated facilities and or medical teams. And as to the people with diabetes, the identified top 4 barriers for healthcare professionals, for people with diabetes are poorly adherence to medication or lifestyle changes, limited patient or family skills to properly manage diabetes, lack of or poor empowerment of persons with diabetes, and poor family educations. I think we will tackle many of these items during these 2 days workshops. As a summary, When looking to these mentioned leading barriers and other ones, to the Barometer survey, to the Down study, and others, we are still trying, it looks like that we are still trying to overcome a chronic disease with acute disease reflexes. We need a coordinated and comprehensive approach at every stage. National plans or strategies for primary, secondary, and tertiary prevention, with monitoring systems in place, and of course with allocated budget. The numbers indicate that diabetes in aging population is a growing problem, as in other chronic conditions. Therefore, there is also an urgent need for the policies and programs for healthy aging. So, thank you.